Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hemong podcast. We're coming at you from Vanderbilt University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we are also continuing our colorectal cancer journey, this time focusing specifically on surgery and the role that surgery plays in the management of both colon and rectal cancer patients. And once again, we have a fantastic guest on our show, Dr. Christina Bailey, who's an associate professor of surgery at Vanderbilt. She is a wealth of knowledge, and I'm so excited for you guys to hear this episode.
Yeah, this is a really important episode where we talk about what really is the best curative option for patients, which is actually taking the tumor out. We do things on the back end to improve the cure rates, but really the improvement in surgical techniques and what we do now, specifically in rectal cancer, has really changed the game for a lot of our patients. So really excited to talk about the nuances of surgery and stuff you just don't hear in medical oncology fellowship.
I always love when we reach outside of our little internal medicine subspecialty bubble and get input from our colleagues around different departments. And so I'm really excited for today too.
Totally. So let's go ahead and roll that show, y'all. Guys, we're so excited to be here today with Dr. Christina Bailey. She's an associate professor of surgery at Vanderbilt University Medical Center and also the program director for the General Surgery Residency program at Vanderbilt. And Dr. Bailey, from your bio, it was so fitting to have you on our show. Your interests are in GI malignancies, so it's perfect for our colorectal cancer series. And from what I can tell, your research is also on cancer disparities and other factors such as socioeconomic factors and race, all of which we know have huge impacts, especially in the colorectal space. So we're so excited to have you here today. Thank you so much for taking the time and joining us.
My pleasure. Thank you for the invitation.
So we always like to start by asking our guest one fun fact about themselves. So please, could you share one fun fact about yourself?
So one fun fact about me, I like to watch a lot of mindless, or in the words of my husband, garbage TV. So I am constantly on Netflix, and two of the current shows that I am currently watching is The Circle and Is It Cake?
Is It Cake? My wife and I watch a lot of trash, lots of trash. What is It Cake? Explain that one.
So it is literally just as it sounds. And so they have this group of bakers, and they're given like these real life objects. It can be a telephone, a hamburger, and you have to recreate it. And the judges basically get, I think it's like 30 seconds to look at the cake that you made and the real thing to decide which one is cake.
It's a truly artful show. I've seen a few episodes of it, and it's pretty incredible. You'd think, oh, that's easy. It's cake is cake, right? No.
That's awesome.
These people are very talented.
I haven't started The Circle yet. I'm waiting for a few more episodes to come out, but I'm a huge fan. And
that's a smart thing, because right now it's only like 3 or 4 episodes, and you get to the 4th one and you're just like, I should have just waited till all of the episodes were out.
That's the key. I mean, it's like when you're watching Love is Blind, you got to wait. You got to wait until they're all at least enough for release, but you don't want to get any spoilers. So that's important. I'm actually watching a reality jail show on Netflix. Highly recommend. I forgot what it's called. Unlocked or something?
Unlocked. I've watched that too.
It's so good, right?
Mindless, trashy TV. That's my jam.
Yeah. I like to refer to this as high quality television. It's good energy.
Okay, fair.
We'll change our frame of reference there. Again, we're really excited to have you on today's show. Vivek, do you want to kick our episode off with a case?
Let's say we have a 72-year-old gentleman who came in because he was having some hematochezia, changed to his bowel habits, and he underwent a CT scan by his primary care provider, and it showed rectal thickening, suspicious for a mass. He underwent a colonoscopy, which showed an 8-centimeter distal rectal mass that was less than 1 centimeter from the anal verge, and this was biopsied and found to be adenocarcinoma. He had an MRI of his pelvis, which showed T4B N0M0 disease. So we always bring these cases to a multidisciplinary tumor board. And through this discussion, I kind of want to get into what is an APR, what is an LAR, what is the surgeon thinking here? Let's just kick it off with, we got an MRI for this patient. From your perspective as a surgeon, can you tell us why the MRI is so important for our rectal cancer patients?
Yeah, and I would say specifically as it relates to surgery, the thing that the MRI is helpful for, yes, it gives us our clinical stage as far as our T stage and our end stage to help guide whether or not these patients neoadjuvant treatment. But the thing that is important to me as a surgeon is, and you mentioned this, is how far is the tumor from the anal verge? And specifically, is there any involvement of the sphincter muscles? Because it's really that sphincter muscle involvement that dictates whether these patients are candidates for an LAR or a low anterior resection or an APR, which is an abdominal perineal resection. And really, the major difference between those two is that with an LAR, we are able to preserve bowel continuity. So we're able to put the patients back together again. And of course, with an APR, and this is reserved for patients with sphinctal involvement, and you remove the rectum and the anus, and these are your patients who will have a permanent colostomy.
And so, besides thinking about permanent colostomy with APR, what are some of the long term adverse outcomes that can come about with these procedures?
These procedures are, of course, not benign procedure, and it is very important to have these discussions with patients ahead of time because depending on how much of your rectum that has to be resected really determines really kind of patient's quality of life after surgery. The things that I discuss with patients, particularly my patients who I'm having to do a low anterior resection for, is their bowel habits will change. And it really stems from, the sphincter serves as a reservoir. And if you're losing a portion of that reservoir, you're not going to be able to store as much stool. So patients frequently have softer bowel movements, also more frequent bowel movements, and that can range anywhere from 2 upwards to 6 bowel movements a day, just depending on how much rectum that you're going to have to resect. And the other thing that you have to be cognizant of is the majority of patients that, at least that I see with rectal cancer, have locally advanced disease. So they're receiving neoadjuvant chemotherapy and also radiation therapy, which also increases their risk for complications after surgery, including sexual dysfunction. Patients are also at risk for urinary retention. And the reason for this is when you are doing your dissection to free your rectum from your pelvis, really right behind your plane of dissection are your parasympathetic and sympathetic nerves that supply the nerve supply to your bladder, and men to your sexual organs. So it is very important to have these discussions with patients ahead of time so they have a good understanding what potential things can happen, and also having a good understanding that their bowel function and their bowel habits are going to change after surgery.
And is there something that really tells you, so involvement of the sphincter muscles themselves may change the surgical management? Is there anything else that would change whether you were thinking about an LAR versus something like an APR?
Yes, is the answer to that question. I wish it was as cut and dry as, okay, sphincter involvement, non-sphincter involvement to dictate between the LAR and APR. And this becomes more of an issue in people who have low-lying distal rectal cancers. I use the example of, say you have a patient who has a low-lying rectal cancer that is not involving the sphincter muscles, but is only, let's say, a couple millimeters away from your dentate line and your sphincter muscles. In those patients, you can still do a low anterior resection in those people, but the way that you put these patients back together is different because you don't have a big enough rectal stump to do a stapled anastomosis. So this is a subset of patients where we actually do a hand-sewn anastomosis. But as you could imagine, the function in those patients could vary based on age, based on their size. So I do have some patients who would be a candidate for a hand-sewn anastomosis, but they're 80 years old. They already have poor function in regards to just their overall rectal tone. And in that subset of patient, I actually would do an APR, even though the sphincter muscles aren't involved. And if you take that same scenario, but I have a 30-year-old patient with the BMI of 25, then that is one subset where I would do a low anterior resection with the hand-sewn anastomosis. So there are nuances in that discussion that are not always as cut and dry as sphincter involvement, yes or no.
I'm somewhat embarrassed to admit that literally up until now, I didn't really understand the difference between an LAR and APR. No judgments here. This is a judgment-free zone. But I think no one's really ever explained that in such simplistic language before, and it makes so much sense. And I think maybe I'll be able to follow GI tumor board a little better now that I know that. Dr. Bailey, we tend to read about total mesorectal excision improving local recurrence rates in rectal cancer. Could you just talk a little bit about what this term really means, especially to people like us that are medical oncologists?
Well, if it makes you feel better, I didn't know what that term meant until I was a general surgery resident. Because you hear this term, total mesorectal excision, and you're just like, well, what is the mesorectum? And I think the most simple way to explain it, essentially what the mesorectum is, it is basically the fat around the rectum. And historically, when surgeons would do a low anterior resection or they would do an APR, they essentially would, for lack of a better term, just basically either using scissors or their hands just kind of cut straight down to the pelvic floor to remove the specimen. So as you can imagine, that would leave a lot of that mesorectal tissue and lymph nodes behind, which of course increase the risk of local recurrence. But now when we do these procedures, we actually identify that plane between your mesorectum and your pelvic. So posteriorly, you see that plane between your mesorectum and your sacrum. Then you basically follow that plane of dissection laterally, then anteriorly. And literally, you just follow that plane all the way down to your pelvic floor. And that's your mesorectum. So it's essentially the rectum plus the fat, which is where all the lymph nodes are.
And that makes perfect sense why that would improve local recurrence rates, because you're not leaving something behind, which I think is really important. And we talked about this in our earlier episodes with chemotherapy trials in an era before this was a commonplace thing. It's really hard to interpret that data. And I think it's just really important for us to just know what that is. And I think in internal medicine residency, I didn't think about the mesorectal fat at all, but it's good to go through that again. So another thing that I think is really becoming a hot topic right now when we think about total neoadjuvant therapy is this idea of non-operative management for some of our patients. And it kind of cuts both ways, with radiation versus no radiation in the Prospect trial. And then we had the Oprah trial, which had some really interesting results. So as a surgeon, what are your thoughts on non-operative management of rectal cancer, and which type of patient would you think you would select that?
Yeah, so this is definitely an interesting topic and also a hot topic within the world of surgical oncology. I was actually having this discussion with one of my residents, and I feel now with all of the changes in how we treat rectal cancer that 5 to 10 years from now, I may not have a job because all of our patients are going to be receiving non-operative management of their rectal cancer. But I will say I am a fan, and I tell my residents and even my patients, not to say that I want rectal cancer, but if I did so happen to get rectal cancer, I would 100% want total neoadjuvant therapy. And if I had a complete clinical response, I would be elated not to have a portion of my rectum taken out. And it really goes back to those complications that we discussed earlier in regards to the risk of low anterior resection syndrome, the risk of sexual dysfunction, bladder dysfunction, which can definitely have an impact on your quality of life. But I will say the caveat to non-operative management, so for patients who do have a complete clinical response in response to their neoadjuvant therapy, these patients have to A, be aware, and B, willing to follow a pretty stringent surveillance protocol. Because for the first 2 years after completing their therapy, they're seeing their surgeon essentially every 3 months for MRIs of the pelvis, flexible sigmoidoscopies, and CT scans. So I think that's the one major caveat with the non-operative approach is you have to have a reliable patient who's going to be consistent with the follow-up.
It reminds me a lot of seminoma, where we have those patients who are just doing surveillance and not giving them chemotherapy that we see in med-onc world. One of the other questions I had for patients who have not locally advanced rectal cancer, but now let's talk about tumors that are managed surgically, that we don't have to do things like chemotherapy and other modalities. Do you think those patients should also be considered for non-operative management, or for those earlier stage tumors, do you think that the risk benefit of surgery is worth it just going ahead with operative management?
Yeah, in the subset of patients with early stage tumors, I do agree with surgical resection, because then if you're giving everyone chemotherapy, radiation therapy, then you run the risk of overtreating patients. And then also chemotherapy and radiation therapy are not benign modalities. They also have their inherent risk associated with them. I will say for patients with early stage rectal cancer who are not receiving radiation therapy, those risks, as far as for large urinary dysfunction, sexual dysfunction, decrease because you're eliminating the radiation therapy.
That makes a lot of sense. And we know with radiation, there's just a lot of scarring that forms, that sort of thing. So if you have a patient who is having surveillance and they end up having recurrence and require surgical intervention at that point, is there a significant difference in how those operations go just because of that extra scar tissue that forms?
I will say in the past, that was the thinking. Is after radiation therapy, it was typically recommended that these patients undergo their definitive operation within, depending on which protocol or study you read, anywhere from about 6 to 10 weeks was kind of the recommended time frame for surgery. And the reason for that was due to concern for potential scar formation after radiation therapy. But I will say one thing that we have learned, particularly now that vast majority of all our locally advanced patients are receiving neoadjuvant treatment, and they're usually receiving their chemoradiation first, followed by chemotherapy. So for those patients who do need an operation, they're already 5 to 6 months out from finishing their radiation. And what we found is, from a technical standpoint, as far as the ability to do the surgery, see the planes, it really hasn't made the surgeries more difficult. So we're not seeing this overwhelming presence of scar tissue from their radiation therapy. And I've actually operated on some patients who've had, an initial complete clinical response, but during their surveillance was found to have recurrent disease that I've taken back to the operating room 1.5 year later, and I haven't noticed any increase in difficulty due to scar formation.
That's awesome. I want to shift gears a little bit to colon cancer. And so that was a fantastic discussion on rectal. We have a tendency to lump colon and rectal together, yet we know from, at least definitely from a medical oncology standpoint, they're very different diseases and we approach them very differently, as we've already been alluding to. Just starting with the very basics, when you're seeing a patient with a colon mass that's consistent with colon cancer, how do you counsel them on similarly long-term side effects? And how do you decide even how much of the colon to remove if they have a colonic mass?
So, as far as long-term side effects from colon resection, the biggest difference that patients may notice, similar to rectal cancer, is a change in their bowel habits. And usually, like if you normally have one bowel movement a day and we remove your right colon, your new normal may be 1 to 2 bowel movements per day. We typically don't see as many changes as we do in patients who have surgery for rectal cancer. But I will say one thing is that they may have a slight increase in the number of bowel movements they have. Then we have some patients who notice no change or no difference whatsoever. As far as when I'm counseling patients, as far as how much colon is going to be taken out, because patients will always ask, is it going to be 6 inches, 12 inches? And really, what I tell them is really not a measure of, oh, I need to take out 6 inches of your colon, 12 inches of your colon. I make my decisions on where to divide the colon really based on the blood supply. For example, if I have a patient who has a right-sided colon cancer and is at the hepatic flexure, I want to make sure that I am removing all the lymph nodes that are draining the right colon, and the lymph nodes travel with the blood vessels. So my approach at the time of surgery is essentially identifying and ligating the blood vessels that supply the right colon. So I divide the ileocolic artery, also the right colic artery, and the right branch of the middle colic artery, because those are the blood vessels that supply the right colon. And where I divide the colon is actually based on the blood supply to the colon. So on average, for right colectomy, we're usually removing anywhere from 10 to 12 inches of the colon, but that can vary because, like I said, the points of transections are based on where those blood vessels are. And if you take that approach, then it also ensures that you're going to remove the appropriate number of lymph nodes. So I know the minimum lymph nodes that you need to remove to ensure adequate colon cancer staging is 12. And if you're basing your dissection on the blood supply, you're going to get that 12 lymph nodes minimum. What we run into issues is when people do, I call them non-formal colon resections where, okay, there's a mass at the hepatic flexure. I need to take 5 centimeters proximal, 5 centimeters distal, and I'm just going to remove those lymph nodes that's draining that portion of the colon that I resect. But you've left all the lymph nodes that are arising from your ileocolic vessel, all the lymph nodes arising from your right branch of your middle colic. So that's how I educate my patients when I'm talking to them about colon surgery and how much colon I'm going to remove. It is 100% based on where the lesion is and the blood supply to that portion or segment of the colon.
It makes so much sense. One of the things that I've noticed, and I don't know if it's just the center we're at, is that it's very rare to see less than 12 lymph nodes removed on these pathology reports. We always talk about T4B tumors having this really poor prognosis in some older studies. And I always wondered, was there inadequate lymph node dissections for some of those patients? In the modern era, how often, as a colorectal surgeon, is it that it's common that we're leaving these lymph nodes behind, or is it a very rare scenario? Is it that when somebody presents with like a obstructing bowel obstruction mass or something like that with some perforation or something that you're not be able to get the lymph nodes, or is it just really not happening that we're having less than 12 lymph nodes examined?
I will say, particularly now in the modern era, that is, particularly here at our center, is very rare. And like I said, it has everything to do with ensuring that you are removing all the lymph nodes drained in that portion of the colon. And even I know you brought up, if a patient presents with an obstructing lesion. So if you have a patient who has an obstructing sigmoid cancer, my surgery would be the same as if it was non-obstructed, is mobilizing your sigmoid colon, identifying your sigmoid artery, ligating, and ensuring that we're removing all of your sigmoid colon and dividing distally right at that rectosigmoid junction. So I think as long as people are intentional about where they're dividing their anatomy and are basing their transection sites, both proximally and distally, based on the blood supply, then that's going to ensure that you're going to get your 12 lymph nodes. And I would say really the only time where I've seen where we really have to sometimes even go back to look at the specimen are more so in your patients, like say you have a patient with locally advanced sigmoid colon invading the bladder and they get 12 cycles of chemotherapy then sometimes in those settings you may get 11 lymph nodes. But a lot of times, if you ask the pathology to go back, it's usually just a sampling error. They're able to find more lymph nodes.
That makes a lot of sense. And we've been talking about dividing arteries and anastomosis, and then these are sort of large abdominal surgeries. We know that chemotherapy, we think about that as affecting dividing cells and healing in that regard. How long do you generally advise people wait before starting adjuvant chemotherapy after one of these operations?
It depends on the approach, whether it's a minimally invasive approach versus an open approach. So with the minimally invasive surgeries, really the benefit to it is people typically have less pain, shorter time in the hospital, and they usually recover faster compared to an open operation. Fortunately, oncologically, the results are the same, whether you do it MIS or open. But if I have a patient that I'm able to do robotic lower anterior resection, their typical recovery is 4 to 6 weeks as far as getting their energy back, getting their appetite back. If it's minimally invasive, I would say 4 to 6 weeks. Whereas for open operation, as you can imagine, it takes a little bit longer. So usually about 6 to 8 weeks on average for patients who undergo an open resection.
The last thing that I'm curious about, we have already on our show talked a little bit about oligometastatic colon cancer. And the amazing thing in oncology now is that even patients with oligometastatic cancer can still have great outcomes, and we can still talk about cure with these patients. So how do you think about patients who would be good candidates for definitive local resection and treatment in the presence of metastatic disease?
So this is kind of a show all in of itself, but I will say for me, my approach to these patients is, can we resect their different sites of disease with a negative margin? I'm pretty sure you guys have seen these patients as well who have lung metastasis, liver metastasis, and still have their primary intact. But I would say if they have one or two lung mets and they're all close together and they are good candidates for a wedge resection, they're candidates for liver resection, and I think those are perfect candidates for consideration for a mastectomy. And so I really just think that varies on where their metastatic disease is. Is it amendable for resection? In some instances, even radiation therapy. And also, I think it's also important to get a sense of their tumor biology. So the vast majority of these patients who present with metastatic disease are getting some form of chemotherapy. And if they're getting chemotherapy and their disease is actually improving, not progressing, I think those are good candidates. Conversely, if you have someone who's getting chemotherapy and their other sites are popping up while they're on chemotherapy, then their disease biology is showing us, okay, this is aggressive disease. And even though their disease may be resectable, this may not be an appropriate candidate for resection, just given their disease biology.
It's really good to know that we are able to do things nowadays we weren't doing in the past. The total mesorectal excisions and rectal cancer, thinking about non-operative management. And then now we have in colon cancer, the immunotherapy. We didn't talk about dostarlimab and the amazing things we have for MSI patients. And it'll be really interesting to see how the field changes from here. This was a great discussion. We always end our episodes with our guests to allow them to kind of say what thoughts you have for our listeners and any final take-home points for today.
Thank you for inviting me. It's been really fun. I would say take home points is, and you've already mentioned this, is really the way that we manage both colon and rectal cancer is evolving. It's an exciting time, just given the things that we're able to do and we're able to offer patients. Just to summarize, for when we do a lower anterior resection versus an APR, primarily is based on sphincter involvement. For patients who are receiving total neoadjuvant therapy and have a complete clinical response and are candidates for non-operative management, they have to be willing to undergo very close surveillance. For colon cancer, when you're thinking about how much to remove, those transection sites are based on the blood supply to ensure that you're going to remove all of the nodes that you need. And also just remember that everything has a price. None of these modalities are benign, be it chemotherapy, radiation therapy, or surgery. But it's important to know what those risks are so that you can have these discussions with your patients.
That was awesome and such a good summary of everything that we discussed. Excellent takeaways in case anybody missed anything, because truly, I've learned more today than I think I have in the last couple of years, which is again embarrassing to admit. So thank you so much once again for being here. Thank you for enlightening us about the role that surgery plays in the management of our colorectal cancer patients. I think that wraps up another fantastic episode. So until next time, we'll see you all later.
See you later.
Peace.